Hello and welcome to the SRNA Ask the Expert podcast series. This episode is an open Q&A on acute disseminated encephalomyelitis and was moderated by Krissy Dilger from the Siegel Rare Neuroimmune Association. Our guest is Dr. Linda Nguyen. Dr. Nguyen is an assistant professor in the Department of Pediatrics at the University of Texas Southwestern. You can find her full bio in the podcast description. SRNA is a nonprofit focused on support, education, and research of rare neuroimmune disorders. You can learn more about us on our website at wearesrna.org. This episode is made possible in part by the generous support of Amgen, Alexion AstraZeneca Rare Disease, Genentech, and UCB.
Thank you so much for joining us today, Dr. Nguyen.
Thank you for having me.
All right, I think we can get started. So to start us off, do you mind just giving an overview? What is acute disseminated encephalomyelitis, or ADEM?
Yeah, I think the name itself speaks volumes in terms of what it is. It's acute, meaning it presents rapidly, usually over a span of a few hours to a few days of progressive neurological symptoms. Disseminated, meaning it affects, multiple areas of the central nervous system. And encephalomyelitis, meaning it can affect the brain, spinal cord, and sometimes also the optic nerves.
Thank you. And what causes ADEM?
Yeah, that's a great question, and it's an evolving question as well, with more recent research finding out, about the MOG antibody and such. But underlying it, it's thought to be an immune-mediated disease where the immune system gets activated and gets confused such that it starts attacking your central nervous system in a wide variety of ways, whether it be the, as I mentioned, the brain, the spinal cord, or the optic nerve.
Got it. Who is most commonly affected by ADEM? Is it more common in children than adults?
Yeah, so I'm mainly pediatric trained, and I see a lot of children, less so adults, and so I see a lot of ADEM because ADEM is more common in children, especially those that are less than 10 years old, than adolescents or older, and then adults.
Okay, great. So what are the most common early signs and symptoms of ADEM, and how quickly do symptoms typically develop?
Great question. And so a lot of what we know about ADEM is that many cases, majority of cases, usually 50 to 70% is preceded by an infectious illness. So you can have a cold or a GI bug, and then a few days or a few weeks later, develop symptoms that we think is part of ADEM, which it can include fever, it can include headaches, but most of the time, by criteria, it has to include ultra mental status or encephalopathy, which, is just a big term to say you have ultra behavior, whether that be excessive fussiness in a child, excessive sleepiness, confusion, disorientation, and then you can have other focal neurological deficits such as weakness of the legs, of the arms, vision loss, etc.
Got it. So how is ADEM diagnosed? What tests are usually involved?
Yeah. So, there's a criteria for the diagnosis. And in children, the two main criteria is that you have to have the clinical presentation, which is you have to have encephalopathy or altered mental status or behavior, and you have to have the imaging findings that is consistent with what we call ADEM, which is multifocal areas of injury, usually in what we call the white matter of the brain, but it can also involve other areas, but multifocal, meaning multiple areas at least.
Good. So how has our understanding of ADEM evolved with the expansion of our understanding of MOG antibody disease? What is the connection?
Yeah, before MOG antibody disease or MOG antibody was commonly used in now testing, ADEM there wasn't a bucket between what's ADEM and MOGAD. And so a lot of the cases was this term ADEM. Some of the cases became multiple sclerosis. Some of the case become labeled with other diseases. Now with the MOG antibody test readily available, we're finding that 50 to 70% of the patients are actually diagnosed with MOGAD or MOG antibody disease rather than ADEM, which changes the whole label and also our understanding of the underlying disease or mechanism that what we call ADEM.
So do you foresee that in the future, as developments kind of continue in this area, that ADEM might be parsed out into kind of smaller and smaller pieces as the causes and the different antibodies that may be associated with it are discovered?
Yes, I think so, because when we say ADEM, we are trying to put, when you come into the hospital and the doctor says you have ADEM, we're looking at sort of the picture overall, but we don't actually have the exact cause of it. And I think as, we do more research and we find out the underlying biology, we're going to, ADEM itself, it's going to be a much smaller and smaller percentage of what the actual diagnosis is. And it's more just, description of what you present it as, rather than what's the underlying cause.
Got it. So should everyone who is diagnosed with ADEM be tested for the MOG antibody?
Yeah, I think this is very key in sort of figuring out what the underlying biology of this medical diagnosis is. And so I would recommend everyone get tested when they have this diagnosis. It's most important, if possible, to get it tested at disease onset, because that's the time that the test is going to be most sensitive, which just means it's most likely going to pick up if you have a positive antibody. But certainly, even if you're 6 months, a year, several years out, I think it's still worthwhile to test for that antibody if you haven't already done so.
Got it. So we did get a question from a member of the community. If a child is diagnosed with MOG positive ADEM, what is their relapse rate?
Yeah, that's a great question, because we always, certainly we always want to know what to expect, in the long term. And the literature is evolving on that. If you don't have the antibody, you're thought to have a lower risk of relapse than you have if you have the MOG antibody. There's different, relapse rates published in the different cohorts that are out there. And I think it can vary anywhere from 25% to 50% if you have the MOG antibody. But just speaking in broad terms, if you have the antibody, your risk of relapse is higher than if you don't.
So I know you are trained in mostly pediatrics, and that's the patients you mostly see. But is there recurrent ADEM in adults as well?
That's, ADEM itself, whether it be recurrent or just a one-time event, can present in both populations. But it's much rarer in the adults. When anyone, whether it be a child or an adult, presents with recurrent ADEM, we always want to try to find out and dig a little deeper about what is the underlying cause. Like, is this because it's MOG antibody disease that's presenting as a recurrent ADEM? Is this multiple sclerosis, et cetera? And so we feel like ADEM by itself as a diagnosis or, is usually monophasic. When it presents recurrently, we think of some other things that are ongoing, and we try to investigate a little deeper. And so, yes, I think just like in children, in adults, you can have recurrent presentations of ADEM.
Got it. Yeah, I think this is a topic in our community that it can be kind of tricky to explain and talk about, that ADEM can be both a diagnosis and a presentation. And those aren't exactly the same. It's a nuance. So I guess in that vein, what is the difference between ADEM as a diagnosis and ADEM as a presentation? Like, can a person have both transverse myelitis and ADEM, or ADEM and another disease, or is ADEM just a symptom or presentation of that other disease?
Yeah, so it can be very confusing because you can initially be called ADEM, and then later on they say you have something else like MOG antibody-associated disease, and so you're wondering which one do I actually have, and so as a physician we kind of think of diagnosis as what we can call you. What we can put a label on after evaluating all of the information we have, your presentation, your imaging, your laboratory results. And so a lot of the times when there isn't a specific cause identified or a disease, then we just put together the picture, and the picture best represents ADEM. And so ADEM itself can both be a presentation and a diagnosis. Now, the diagnosis can change over time. As I mentioned, if you discover that you have MOG antibody, then your diagnosis changes to MOG antibody-associated disease. Or if you have another disease or another neuroinflammatory disease that is later discovered based on other testing or other presentations, then your diagnosis changed. But still, you presented with ADEM. So again, ADEM can be both. One are diagnosis and presentation, but the diagnosis can change over time.
Got it. Yeah, that makes sense. So I know also we've talked about how ADEM and MOG are associated, or other things. Can you talk about, can ADEM be mistaken for other neurological conditions such as autoimmune encephalitis or NMDA receptor encephalitis, like other I guess encephalitis diseases?
Yeah, I think that, when we think about sort of other things, we think about mimics in our world. And so in order to be diagnosed with ADEM, it's sort of a diagnosis of exclusion. So if you don't have any other things, like no infection that was found, no other, disease that could explain it, oftentimes you get diagnosed with ADEM. And so ADEM can be a descriptive sort of thing, but you always have to think about, is there something, again, underlying this? And so mimics, things that you have kind of think about, alternative diagnoses would be, as you mentioned, autoimmune encephalitis. Because autoimmune encephalitis can certainly, meet that criteria that I previously alluded to, ultramental status and multifocal brain changes. And so certainly if you just, check those boxes, you can technically be diagnosed as ADEM. But what is the better diagnosis? Is it autoimmune encephalitis or is it ADEM? And then certainly other, even, not necessarily just neuroinflammatory conditions. Sometimes we have to think about metabolic mitochondrial conditions as well before we put a label as ADEM, because we think ADEM as, an immune mediated, and we give all those strong immunotherapies, which wouldn't be good if you had a genetic metabolic condition.
Got it. Thank you. So what treatments are most commonly used during the acute attack phase?
Yeah, so during the acute attack period is where we think the inflammation is at its highest level of activity. And so we try to quiet down and dampen or stop the inflammation. And we do that by giving immunotherapies. And so that includes, in the acute setting, most commonly IV steroids, usually over a course of 3 to 5 days. And then oftentimes, depending on the severity of the presentation and the response to the steroids, we then move on to adding either plasma exchange into the regimen and or IVIG.
Got it. And what does recovery look like for someone who is newly diagnosed with ADEM?
Yeah, I think recovery depends on a lot of different factors. And so it's unique for each patient. But I think in general, recovery, depends on how severe your presentation is, how much was affected. Did you have, both spinal cord involvement and brain involvement? And then how quickly the immune therapies were started, because we know that any earlier initiation of immune therapy improves long-term recovery, not just quicken the recovery, but also improve the amount of recovery. But typically, in general, usually you're in the hospital anywhere from a few days, if it's the milder case, to several weeks, receiving the acute immunotherapies we talked about. And then, if you're able to go home, then and you can follow up with outpatient occupational therapy, physical therapy, et cetera. You can do that. But some patients require inpatient rehab stay, anywhere from a few days more to even 2 to 3 weeks more. And so that's just the acute sort of hospitalization period, which can span usually a month or less, and then in more severe cases, longer. But the recovery period outside of the hospital can take several months more, especially for more of the milder symptoms like cognitive function, processing speed, bowel bladder function. Those can take much, much longer.
Got it. So would you say, long-term wise, are there effects that can last long-term for ADEM even after that initial year or so after the event happened? And can you talk a little bit more about those long-term effects and then also how they might differ between children and adults?
Yeah. So I think that, the good thing is the majority of patients have very good functional outcomes after ADEM. Both, I think, in the children and adult world, this is thought to be, you get peak severity during the hospitalization, and then you continue to improve, and then you really make good functional recovery, meaning that you're able to return to work or return to school. But the residual symptoms we often see that might, not be so obvious is cognitive function may be affected, whether that be, attention, short-term memory, and processing speed. And so that can certainly affect, school and work for children and adults. Sometimes we also see mood symptoms being commonly following, such a major disease and hospitalization. And so we always say to monitor for those, depression and anxiety. And then the other sort of motor deficits, we often see improvements in that, the most gains in those areas. And then in terms of recovery, comparing children to adults, I think that the child's brain is more resilient. And so I think they do make more substantial and quicker recovery compared to adults.
Got it. That makes sense. I know in the past we've talked about neuroplasticity and how that can affect how someone might recover, and age could be a factor in that. So totally makes sense. So are seizures common for people with ADEM?
So I think in terms of common, I think yes. I think about maybe a third of children can have seizures, or and then especially if on their brain MRI they have an area called the cortex being involved, because that's where a lot of the seizures originate from, and so um, we see seizures as a presentation. Oftentimes, though, in the long-term recovery period, we can often come off seizure medicines or not be on seizure medicines, because the idea is, the inflammation is gone, and the risk for what we call epilepsy, which is recurrent seizures, is not high enough to justify being on a long-term anti-seizure medicine.
Got it. So someone from the community asked, how can you tell whether your child's changes in personality or temperament are coming from the ADEM event or just general maybe stress or aging of the child? How can you tell, and what to do about that?
Yeah, I think, especially in children, it might be difficult to discern, but usually what we would think about in terms of, ADEM is a progressive change in behavior or mentation. And so they should, if they're, fussy for a day and then they get better the next day, I wouldn't worry about, ADEM. But if they're fussy, and they start to become more sleepy, and then their gait is a little off over the course of a few days, then I would be worried that this is a recurrent inflammatory brain hit.
Got it. And how can families support a child emotionally during a recovery? Do you have any tips or anything that you think parents should know or keep in mind after their child might be diagnosed?
Yeah, this is, oftentimes the child, as I mentioned, is encephalopathic. So they might not even remember the hospitalization, but certainly they remember, something was wrong. And so it's sometimes when, they're asking questions about it or whatnot, try to explain it, in terms that they can understand. If they have frustrations, certainly validate those frustrations. It's always important to look and, see if, look deeper if there's developing mood symptoms, whether that be anxiety or depression, because that can certainly be one of the symptoms we, commonly see post-ADEM, beyond the cognitive dysfunction. And then making sure, whether it be the school or work, there's accommodations in place to help the child or the, person be able to function as best as they can out in that environment.
Got it. Things like maybe IEPs and 504s for
Yeah.
schools,
Yep.
and other disability rights things
Yeah, it
for
might
work
not just be
accommodations.
exactly, and it might be, not necessarily. It can be as simple as breaks, with accommodations, because one of the symptoms that we often see post neuroinflammatory conditions is fatigue, and so having breaks in classroom settings or in the work environment is important.
Got it. We did got a question. how often should patients have follow-up MRIs or neurology visits after their event?
Yeah, I think it also this question I think depends on the underlying cause of ADEM. If it's just we didn't find an underlying cause, then typically what we do is we get an MRI 3 to 4 months after the initial attack. We get this because we want to get a new baseline in case something happens in the future, and we want a good reference point. Because ADEM, as I mentioned, is a multifocal brain disease. And so the first MRI you get in the hospital may change and evolve over time during the sort of disease course. And so in the recovery period, we like to get the new MRI just so we can get a new baseline for comparison. And then if you have MOG antibodies or multiple sclerosis or something else, the sort of frequency of the MRI is different.
Got it. Thank you. So are there warning signs that might suggest a relapse is potentially coming on, or perhaps another neuroimmune disorder is developing?
Yeah, and so when you have ADEM, it's thought to be a demyelinating disorder affecting the white matter tracts of your central nervous system. And so you can present with another attack of ADEM, which is unusual, but more commonly you affect other parts of your central nervous system. So oftentimes when we think about potential symptoms of relapse, we think about vision loss that's associated with optic neuritis, weakness of one limb or one arm, trouble walking, trouble going to the bathroom, whether that be you're not able to go to the bathroom, or you're having increasing frequency, signaling inflammation of the spinal cord or myelitis. Those are the more common relapsing symptoms. It's unusual to present again with ADEM.
Got it. So we could get another question. Are fatigue and headaches common after ADEM? I know we've talked about this, but can you talk a little bit more about the treatment for this fatigue and headache?
Yeah, as I mentioned, with ADEM or really any other neuroinflammatory conditions, fatigue is common, but also headaches. And ADEM particularly because you have such oftentimes diffuse involvement of the brain and neural axis. So to try to address these things that we commonly, hear patients voice concerns over, for fatigue, it's very important to address any sleeping issues and sort of optimize sleep hygiene, and then trying to engage in physical activity as much as possible usually helps with fatigue component. And then for the headache component, it's very interconnected, really. Obviously with headaches, we try to make sure that your lifestyle is addressed, whether you're drinking enough water, avoiding caffeinated beverages, sleeping enough, sleeping regularly. And also, a big component of fatigue and headaches is also mood symptoms, because exacerbated mood can certainly worsen fatigue and headaches as well. And so we try to be, holistic and address, these common symptoms as a whole, not, trying to address, the whole system rather than, giving a medicine for everything. We always try to see how it could interlink and then, address multiple things that could contribute to it. Mhm.
Got it. We got a question from someone whose child was diagnosed at the age of 5 with ADEM, and as a consequence has paralysis and some other cognitive issues. They were wondering if there's any natural or alternative types of medicines that can potentially help somebody with ADEM years down the road?
In terms of natural supplements, beyond what we recommend, which is like a vitamin D, and making sure that your vitamin D levels are normal or above normal, there hasn't been great data to say a certain supplement will improve, the recovery period or remyelinate the areas of injury. And so unfortunately, there isn't one specific thing that has been shown to be beneficial. We like vitamin D in general because it's important for immune health.
Got it. Thank you. We do get this question sometimes, and someone wrote in to ask if there's a relationship between vaccines and ADEM, and how families should think about future vaccinations after diagnosis. Is there anything you can tell us about that?
Yeah. I had mentioned earlier that this disease is thought to be immune mediated, meaning the immune system is activated, but it's confused, and it starts attacking your brain. So vaccine is not necessarily a cause for ADEM, but in very rare instances, it can be sort of a trigger for ADEM because it activated your immune system, which is the appropriate response to a vaccine. But for whatever reason, for underlying, environmental genetic susceptibility, that specific instance of immune system activation got confused, and then decided to attack your own self. So when we see that or have a patient report that I recently got this vaccine and now I have this presentation, we, obviously every patient's and recommendations individualized, but we often don't say to not get further vaccines, even if that was the sort of trigger for them. In the sort of the literature, ADEM is commonly also referred to as post-infectious encephalomyelitis. And so again, it's that this trigger that we think is whether, in most cases, not a vaccine, but more like an infection that activates the immune system in some way that in a susceptible person develops into ADEM.
Got it. Thank you. Is there any known genetic or hereditary risk associated with ADEM?
For the presentation itself, versus optic neuritis or transverse myelitis, there isn't a specific genetic predisposition. But if it's part of an underlying disease, such as MOG antibody disease or multiple sclerosis, those diseases themselves may have different genetic risk factors.
Got it. So we got this question recently. Can emotional stress or illness trigger symptom worsening during the recovery, even if it's not a full relapse, like with new inflammation?
Yeah, that's a really great question, because sometimes it's hard to discern between what's a true relapse and what's what we call pseudo-relapse. And so when you have ADEM, you have, in the acute period inflammation. And then after the inflammation dies down, you have areas of injury. And so there's always going to be some areas of injury or disrupted neurocircuitry. In times of, in the recovery period, in times of stress, whether that be an infection and you get fever, cough, cold, runny nose, or sleep deprivation, or you're preparing for a test, a very big test the next day, or you're overly stressed from work, that neurocircuitry that's been injured and damaged and hasn't fully healed works much harder under stress. And so you can get symptoms coming back because sort of that signal, between your brain and your actions are slowed or not as effective in firing when you're under periods of stress. So you can have old symptoms coming back, and that be considered a pseudo-relapse. Now, if it's progressive symptoms evolving over 24 to 48 hours, then that can signal to us maybe that's more due to new inflammation that's taking place, rather than the injured network just working a little harder under times of stress. And so how we frame that is, if you remove the stressor, like if you remove the fever and the infection and your symptoms improve or get better, then that's unlikely to be due to new inflammation.
That makes sense. Yeah. Thank you for that explanation. So we got a question. What role does physical activity play during recovery? Do you suggest someone to push themselves, I guess, physically, or is rest more important? How was that approached after an ADEM diagnosis?
Yeah, so I think we don't want to, overstress the body, because then that can have the sort of counterproductive effect of making things worse because of that neurocircuitry firing a lot harder. But we don't want to not use, our muscles and our skills. And so there's a balance between that. Certainly in someone that has motor deficits or functional deficits, it's very important to maintain visits with your physical therapist and occupational therapist to continue to work at it. And, with the idea of neuroplasticity, the more you work at it, the more stronger the signal gets, and, the stronger you get. And so it's important to continue to work at it, but there's a fine line between continuing to work at it and then overstressing your body. And so each patient is going to be, their level of physical activity is going to be different. Some patients can tolerate, going to the gym for an hour, and some patients can tolerate 3 hours. But I think it's still important to maintain some level of activity, but then also listen to your body.
Got it. Makes sense. Are there any, so we get a lot of questions regarding research into ADEM and all the rare neuroimmune disorders. So I was wondering if you could tell us anything about current research that's being conducted, or alternatively, any kind of factors that you're hoping that are most important to look into in the future for ADEM.
Yeah. I research is so important in this field, whether it be you have ADEM or not, because we're just trying to find, ways to improve outcomes and improve prognostication, whether you have another relapse or not. And so it's very important to try to be engaged and involved in research. And at our institution, especially in our Demyelinating Disease Clinic, we keep a biorepository where patients can simply donate their blood or allow us to keep track of their medical data in a bioregistry or data bank. And so it can be as simple as that in terms of participation. And so for us, we're very interested in looking at ways to better understand disease biology and also better understand predictors of disease. And so, especially in the context of MOG antibody disease, which is the more recently identified antibody. And we're very interested in seeing, what does it mean if you have MOG antibody-associated ADEM and not? And so those are some areas of investigation we're involved in.
Great. It's very interesting, and looking forward to seeing what kind of results come out of that study. We did get a question about, I guess, long-term effects again, but how Are there any indications during that acute phase that might predict whether someone might have a harder time recovering or might have residual symptoms that last versus someone who might have an easier or shorter recovery and be able to kind of move on without having many symptoms in the long term?
Yeah. Uh, it's always good to know, and an important question for parents, especially when a kid comes in, how will my child look in the long term? There isn't, a great evidence to say one specific thing will make, your outcome far worse than another, because again, there's so many variables that goes into this. Um, it's very interesting because when we look at the MRI of a patient with ADEM, remarkably, even if they have, whole spinal cord involvement, very confluent brain involvement, they can go back to 100% and their MRI be normal, 4 months after the attack. It's remarkable. And so MRI data, certainly we think the more widespread it is, the more likelihood you're going to have, long-term functional deficits, but that doesn't always correlate. So certainly, while in what we think is commonly should be associated, in some cases, remarkably no. But a lot of times, if you're needing more aggressive treatment, like plasma exchange, because you can't, get out of bed, you have a lot of seizures, you're not following commands, that can signal a longer recovery or more residual deficits, especially cognitive deficits. Or if you have delay in your treatment from the onset of your symptoms because, they were worried about infection in the beginning. And so you're going through multiple rounds of antibiotics and not having received the immunotherapy, which is, the treatment. That could certainly make recovery longer and not as great. And so it's really dependent on a lot of different factors. And so we can't really pinpoint one specific thing that will let us know whether your recovery will be good or not. And a lot of times the patient surprises us because we see them, 2 weeks into the hospitalization, they're still really affected. And then 3 months into, the outpatient clinic, and they're back to normal. And so stratifying sort of their trajectory in the acute setting is very difficult. And we tell families that.
Got it. Thank you. We did get a question about transitioning from pediatric to adult care, I guess. So if a child is diagnosed and then they are, going through their teenage years and reaching that moment where they're going to, transition to adulthood and maybe switch over to an adult neurologist from their pediatric clinic, what kind of things should they be aware of? Are there any tips or tricks that you like to use in your clinic to help teens prepare for that transition? Are there any things or factors that they should consider?
Yeah. I think, it depends on what neurology clinic you also come from, because some clinics have a sort of transition coordinator where they prepare the teen who starting, maybe even at age 16 for that transition eventually once they turn 18 or graduate high school. And so some clinics have that, such as our own. But I think, as you're transitioning from being a child to an adult, I think the biggest thing is taking charge, of your medical condition. So, understanding what you have and not being dependent on your parent to provide the information. is important in sort of that transition period. So as you're sort of graduating pediatrics, trying to be the primary person giving the information, the person asking the questions with each visit, and sort of just, being a part of the visit is going to be important in that transition period. Because when you transition from pediatrics to the adults clinic, it's a big change. It's a much different vibe as well. And so I think that's one thing that our adolescents can certainly do, just to be more part of the visit.
Got it. So how would you best, I guess, counsel someone who is experiencing weakness and like their muscles don't seem to be moving quite how they used to before? What would your recommendation be for someone who is experiencing those symptoms?
Yeah, I think it depends on what is possibly contributing to that weakness. Certainly, if it's a residual symptom, continuing to work with physical therapy, not necessarily, going to sessions every day or every few days, but checking in with them on an occasion can be helpful as well, just so that, they're reevaluating you, making sure that if there's specific exercises that can be done that improves your ability to move those muscles and strengthen those muscles is helpful. And as you, learn from the physical therapist, applying those exercises on your own is important, not just during the sessions. And then if it's a sort of a worsening of your underlying weakness, then evaluating what is contributing to that, whether that be because there's, other stressors going on, there is mood symptoms that is not being addressed, sleep issues that isn't being addressed, fatigue, or is it a new sign of disease activity? Are all important things to look at.
Got it. Thank you. Someone wrote in and said that they have had sleep issues recently, and they were wondering if that could be related to the ADEM. And if so, is there any kind of medication or anything else they can try to help them sleep through the night better?
Yeah. So sleep can be a symptom as a result of the brain injury. People that have ADEM are more at risk for developing sleep issues, just like people with other brain injuries like traumatic brain injury or other neuroinflammatory conditions are at risk for. That as a sign of disease relapse would be unusual in itself. So usually it's more a symptom of prior neurological injury. If, if it's new sleep issues, it's always important to address the context of which those sleep issues are coming forth and try and just investigate further. A lot of times, if we, as neurologists, we're not sleep experts. And so if we try the common medications like, melatonin or something like trazodone, and that's not effective, and if it's not a mood disorder, then we do refer to our sleep medicine colleagues, get even a sleep study to look at sort of the efficiency of the sleep-wake cycles to, address the ongoing sleep issues.
Got it. Thank you. I actually think that is the end of our questions. So I don't see any more come in. So we can, I think, wrap it up. I think we covered a lot of grounds, and I'm really happy that we were able to do this.
All right. Thank you so much for all the questions.
Thank you so much, and we'll see you next time. Thank you to our Ask the Expert sponsors, Amgen, Alexion AstraZeneca Rare Disease, Genentech, and UCB. Amgen is focused on the discovery, development, and commercialization of medicines that address critical needs for people impacted by rare, autoimmune, and severe inflammatory diseases. They apply scientific expertise and courage to bring clinically meaningful therapies to patients. Amgen believes science and compassion must work together to transform lives. Alexion AstraZeneca Rare Disease is a global biopharmaceutical company focused on serving patients with severe and rare disorders through the innovation, development, and commercialization of life-transforming therapeutic products. Their goal is to deliver medical breakthroughs where none currently exist, and they are committed to ensuring that patient perspective and community engagement are always at the forefront of their work. Founded more than 40 years ago, Genentech is a leading biotechnology company that discovers, develops, manufactures, and commercializes medicines to treat patients with serious and life-threatening medical conditions. The company, a member of the Roche Group, has headquarters in South San Francisco, California. For additional information about the company, please visit www.gene.com. UCB innovates and delivers solutions that make real improvements for people living with severe diseases. They partner with and listen to patients, caregivers, and stakeholders across the healthcare system to identify promising innovations that create valuable health solutions.